Hello guys, very good evening. Hope I'm audible and visible. A warm welcome everyone. And this was supposed to be scheduled at 10 p.m. today. Since we have a patient management series going on in the Unacademy app at 10 p.m., I'll be taking that at 10 p.m. You must be wondering what pathology will be there in patient management. It has a very huge role. And let's see, you have your patient management series going on with your obstetrics, gynecology, your pediatrics, your surgery. And I'll be ending up with pathology where will be an amalgamation of all the patient managements. It's going to boil down to a lab medicine, right? We'll see that. Today, we are just going to have a very few random questions, mixed bag questions, which is more for a thought process to increase a thought process rather than going and competing against each other, right? So I want you to make a comment. If you are there live here, for every question which I say, do comment the answer. Not only the answer, tell me if possible, tell me how did you arrive to that, fine? Before that, these are the free tests for this week. Hope you make use of it, and the compact is back with cardiovascular system, fine. So that helps you to fetch some prizes. There'll be lots of Unacademy Lite subscriptions will be given out as prizes as well from your 4th to 25th run. Unacademy Lite is a new product from Unacademy where you don't have the video lectures, you have only the tests and discussion, everything, right? And as usual, the Unlock 20 is back. If you guys want to enroll, please do it and use the free lectures as well as the platform whenever you feel it useful, fine. Okay, I'll display the first question. I will mute myself for the next 30 seconds. I want you to comment on the answer. Pratmesh, yes, it was in the Unacademy app at 6 p.m. It's done. You can watch it later on. We'll have one more session in RBCs. I'll definitely tell you when it is. Okay, now SN has started with B, Swati has gone with D. Anyone else wants to add to the answer? Then you'll definitely go and look at the question. It's a simple one. Okay, we'll read through the question and we'll see what will be the probable answer. It's a 55-year-old person, obese, presents to the gynecologist for an intermittent vaginal bleeding over the past 2 months, denies any discomfort, menarche at 9 years, pap smear is negative for HPV, abdomen examination is unremarkable, negative, no lesions or tenderness in the external genitalia. Bimanual thing shows examination is normal, no mass. So with this information, can I rule out uterine leiomyoma? Because if it has been a leiomyoma, some examination finding should have been there, a bulky uterus, something of that sort, right? So I can definitely rule out uterine leiomyoma. Can you rule out uterine adenomyosis? Because adenomyosis will present with intermittent vaginal bleeding postmenopausally, or it will have premenopausal dysmenorrhea. It will mostly have a premenopausal dysmenorrhea, right? I can rule this out as well, fine. So my only possibilities are B and D, right? We'll read through the question. Transvaginal ultrasonography shows endometrial thickness of 4 mm. Subsequent biopsies says that it's an gland to stoma ratio is elevated. There's a mild increase in the glands to stoma ratio. If it would have been a case of an endometrial carcinoma, will there be dysplasia? Yes, you must have encountered a high NC ratio, pleomorphism, loss of clarity, mitose and everything, right? So since I don't have any of the options, I can rule out a carcinoma, right? I can kind of rule out a carcinoma because the only information given here is an mildly increased gland to stoma ratio, right? Can any one of you here comment what is the gland to stoma ratio? Anyone here, can you comment the gland to stoma ratio, the normal gland to stoma ratio? Because that's important for us to understand the microscopic image, right? What do you think is the normal gland to stoma ratio? Great, SN has gone with 1:1. Can anyone add to it? The normal gland to stoma ratio in an endometrial biopsy is 1:1, right? When I say 1:1, let's say these are glands. I'll show a real image. These are definitely glands, right? I'm having glands here. These are all endometrial glands. So the volume of the gland is to stroma in a real biopsy should be 1:1, which means one part of glands and one part of stroma. So when I say there's a mild increase in the gland to stroma ratio, obviously the gland component increases. When I say 2:1, or 3:1, which means there are 3 times volume of glands and just only 1 time volume of stroma. So can I say there are more number of glands? Can I call it endometrial hyperplasia? It is. An endometrial hyperplasia looks like that, right? Whenever you have a tiny elevation of the gland to stroma ratio, more than 1:1, I'm going to call it hyperplastic. Hyperplastic endometrium might not have features of dysplasia, right? So I'll show you one more image. This is how a normal endometrium looks, right? Just compare this normal endometrium to this image. What's happening here? In simple terms, the first comment should be on the gland to stroma ratio. What's happening to the gland to stroma ratio? Elevated, normal. Definitely the gland to stroma ratio is elevated. Yes. So definitely there's an increase in the gland to stroma ratio. So this is the first step to call it an abnormal endometrium. That's all. I can just call it abnormal with this image because there are more number of glands and relatively less number of stroma, right? If it is an adenocarcinoma, what happens is the classical finding, or in a microscopy, what will be there in adenocarcinomas? There'll be back-to-back arranged glands. That's very, very important. I'll tell you what does it mean. Whenever any question says back-to-back arranged glands, the possibility of an endometrial adenocarcinoma is definitely more compared to an hyperplasia. Well, let's take this gland, these two glands. Can I say between these glands there is still a good amount of stroma seen? Can you see the stroma between these two glands? What I have marked? Definitely there's a little bit of stroma. Stroma in sense, yes, there's definitely a stroma here. There's definitely a stroma here. I do see a little bit of stroma, though the glands are very, very close together, but still I do see a little bit of stroma. When I don't see any stroma between two glands, I'm going to call them a back-to-back glands, which means the amount of endometrial proliferation is very, very high. It's very, very high. I think of an adenocarcinoma. There are few pointers for a carcinoma. That's one. Second, obviously the features of dysplasia. When the features of dysplasia are there, I'm going to think of a carcinoma, right? So coming back to the question didn't mention anything about it. It just says that mild endometrial gland to stroma ratio is elevated and various amount of cystically dilated glands. Both will point out to your endometrial hyperplasia only, fine? So the answer to this is simple endometrial hyperplasia, okay? Though the question looks very big, the easier way to rule out carcinoma was hyperplasia. The back-to-back arrangement and little bit of dysplasia points towards carcinoma, fine? Okay, next question. Read through the question. I'll create a poll. I want everyone to comment here. No silent participants. There are no poll. Doesn't matter. Do comment. If you feel your comment is wrong after a discussion, please remove the comment. That's completely fine, but I want you to comment. Okay. Richa's gone with D. Richapal Yin has gone with D. Anyone else want to add it? I do want everyone to comment here. It's fine to make a mistake. Prathamesh has gone with D. It's a simple question. Vicky is D, good. Fine. Quite a few of you have gone with D. One thing which is happy is you didn't go for tuberculosis. That's one happy thing for me because we have been reading whenever it's granuloma, the first possibility is tuberculosis, right? 40-year-old person has dryness, cough, arthritis in an ankle, and multiple granulomas in both the lungs, as well as bilateral hilar lymphadenopathy. You have cutaneous nodules over the trunk, right? What does it mean? Can you give any term to this? Cutaneous nodules over the trunk, leg, any particular term in relation with the diagnosis, which is sarcoidosis. Nodules in the trunk or in the lower limb, any term? Any term for this? Can this fit into erythema nodosum? Okay. This is just a description of an erythema nodosum. We have to look in the biopsy whether it's erythema nodosum or not. Most likely an erythema nodosum, right? Again, that is also a pointer for me towards sarcoidosis. And ESR, elevated erythrocyte sedimentation rate, ACE enzymes, serum calcium levels, all are elevated. I'm just going to give a different perspective. That's all. I just want you to think here. ESR, will it be elevated in tuberculosis as well? Is there a possibility ESR will be elevated in tuberculosis? Yes. Yes. So this will not help me. Fine. This will not help me to come to a conclusion. Okay. So calcium levels, serum calcium levels, let's assume I'm having a patient with an miliary tuberculosis, disseminated tuberculosis, and let's assume the patient has a pot spine. Will the serum calcium levels will be elevated in pot spine? Yes or no? Yes, there is a possibility for serum calcium levels to be elevated in a disseminated tuberculosis, especially when it involves spinal tuberculosis, because there can be lysis happening. Fine. Okay. Right. So why I want you to look for these two is, just because serum calcium is elevated, don't jump into diagnosis of sarcoidosis. Hypercalcemia is definitely one of the possibilities of sarcoidosis, but don't rule out tuberculosis, pot spine. Fine. But AC enzymes has no role in tuberculosis, right? AC enzymes are more important for me. Elevated angiotensin converting enzyme, there's only one possibility, which is sarcoidosis. Fine. I'll come back to your question, Swati. Yeah. See, ESR will be elevated in any inflammation in my body. It's not just tuberculosis. When you cough, when you have a fever, sore throat, ESR will be elevated, right? It's an acute phase reactant due to fibrinogen, like Prathamesh said. Fibrinogen is an acute phase reactant which can be seen in any acute as well as chronic inflammation, whatever it may be. Increase in fibrinogen obviously increases the sedimentation rate, so ESR will be elevated in tuberculosis, right? So my diagnosis is sarcoidosis, right? Let's look at the microscopy. There are few classical findings in sarcoidosis. The first one here, what is this finding? The very, very classical image. This is a classical case of an asteroid body, right? It looks like a star, right? This is an asteroid body. Again, when I see asteroid body on a microscopy, can any one of you tell me any other differential diagnosis apart from your sarcoidosis for asteroid body? Or do you see in any other place asteroid bodies apart from sarcoidosis? Prathamesh, human body will have a calcium concretion. Here the proteinaceous material looks like a star. That's an asteroid body, right? Asteroid bodies can be seen in quite a few conditions. It can be seen in your tuberculoid leprosy. I'll come to it in sporotrichosis. It can be seen in berylliosis. It can be seen in your necrobiotic xanthogranulomas. Asteroid body in sporotrichosis, those are a totally different asteroid body. Though it's named the same, it will not be seen inside a giant cell. So all these conditions will have the same asteroid body inside giant cells, right? So asteroid bodies of your sporotrichosis are different from the asteroid bodies of your sarcoidosis, fine? That's totally different from this. All of them will look exactly like a sarcoid. It will be seen inside a giant cell, fine? Okay, next. What is this finding? This is also a classical finding seen in your sarcoidosis. What is this? What is this? Prathamesh, this is your human bodies, right? You can see this is definitely a giant cell. This entire thing is a cell, single cell. It's definitely multinucleated. That's a giant cell. In the center of the giant cell, I'm having something irregular and blue in color. That's your calcium concretions, right? That's your human body. It's calcium. Can I say a tuberculosis patient on a long term can have calcification? Can they have your dystrophic calcification? A simple TB patient? Yes or no? It is possible, right? Though human bodies are more seen in sarcoidosis, TB patients might also have calcification inside the giant cell. So just because I'm having human bodies or calcification inside the giant cell, don't go for sarcoidosis. It should always be biopsy, biochemical, clinical correlation. It's never a single finding. This alone doesn't make it sarcoidosis. It can be seen in tuberculosis also, fine? This is your Hamasaki-Wiesenberg body. These are actually lysosomal things. I have shared this in your Telegram group as well. The only problem with this is, if I'm going to give you this microscopic finding without an history, what will come to your mind first? Do they look like copper penny bodies? Which condition do you see copper penny bodies? They kind of look the same, right? I'll zoom it a little bit if you want. Though not exactly the same, but definitely looks similar to an copper penny bodies, right? Which disease do you see them? Chromoblastomycosis, right? So we see copper penny bodies in your chromoblastomycosis. That's a very, very close differential diagnosis. The reason why the knowledge of Hamasaki-Wiesenberg body is important is, when you see a chromoblastomycosis, which is a fungus, will it be PAS positive? A chromoblastomycosis, will it be PAS positive or not? any fungal organism will be PAS positive, right? So unfortunately, this Hamasaki-Wiesenberg body is also a PAS positive finding, right? So unless and until I have this thought that it could be in Hamasaki-Wiesenberg body, I might misdiagnose it for Chromoblastomycosis. This will be GMS negative. But it's a fungus. Fungus will be GMS positive as well. If it is a Chromoblastomycosis, it will be GMS positive, PAS positive. Here it will be only PAS positive. Few of the textbook call these in isolated conditions as residual bodies, right? If it's clustered, we use the term Hamasaki-Wiesenberg body, otherwise it's called as residual bodies. These terms, this Hamasaki-Wiesenberg body is a classical finding seen in Sarcoidosis. It resembles your copper penny bodies, which can be seen in Chromoblastomycosis, fine? Okay, read through this question. I'll mute myself for 30 seconds, then discuss the answer. I want everyone to comment. It's a very, very simple question. I'll answer Swati. Okay, most of you have gone with D again. PNH, great. Richapal. Swati, Hamasaki-Wiesenberg body can be seen in any place where we have sarcoid granulomas. Includes your erythema nodosum, includes your lungs. Wherever sarcoids can form granuloma, that's a finding seen there. Right? Perfect. So my diagnosis here is paroxysmal nocturnal hemoglobinuria. Right? Perfect. So every thing here is told with, right? So there are two things which are important for paroxysmal nocturnal hemoglobinuria: CD55 and CD59. Right? These both. What is the other name for CD55? I'll give you two options because it's very big to type. Which of these two is MIRL? CD55 or CD59? Eunice told both. CD55 is your decay accelerating factor and CD59 is your MIRL, membrane inhibitor of reactive lysis, right? In other words, CD55 inhibits which complex? Which of them will CD59 inactivate? Also a CD55, which will they inactivate? These are normal proteins. The function is to inactivate or inhibit your MAC complex, right? CD59 will inhibit your membrane attack complex, which is the terminal effector sequence of your complement pathway. And CD55 will reduce your C3 convertase. Because C3 convertase, it's one of the key steps. It's like a rate limiting step for complement. It reduces C3 convertase. Ultimately, my role is to prevent complement mediated lysis of an RBC. So these are normal structures, right? So these are not defective in PNH. What is defective in PNH? What is defective in PNH? The person which helps these two proteins to bind to the RBC surface, like some of you said that, the GPA anchor. The glycophosphatidylate inositol anchor is defective in PNH, and that anchor is called by PIGA gene, right? So PIGA gene codes for GPA. The GPA is the defect here, right? So let's say it's a mutation related disorder, right? I'm going to ask you a question. Listen carefully and answer. Which chromosome do you see PIGA gene? Which chromosome is the PIGA gene seen? That's a known question. I'm sure you know the answer for that. It's seen with chromosome X, right? It's a gene seen in chromosome X. Fine. Right? So can I say that PNH is an X-linked recessive disorder? Is it possible for me to extrapolate saying that PNH is an X-linked recessive disorder? Yes, it is seen in chromosome X. Is my net perfect? Is it getting stuck? If so, comment. I don't know what's happening. Just give me a second. Okay, perfect. Thank you for your time. PNH is an acquired disorder, right? PNH is not an X-linked recessive disorder, it's an acquired disorder, fine. So what is the investigation of choice for PNH? You must have known many investigations, but I want the perfect thing, the investigation of choice for every case of a PNH. PNH is diagnosed with flow cytometry, right? Okay, fine. Thank you, Pratmesh. PNH is a diagnosis or investigation of choice is always flow cytometry. Okay. So your other findings will, though they help in the diagnosis of PNH, investigation of choice is always flow cytometry. If it is flow cytometry, I'm going to give you two options. Which will you prefer? Is it CD5559 flow cytometry or is it FLAIR's flow cytometry? Because I'm sure you must have read about FLAIR, right? You must have read about FLAIR. So it's 5559 or FLAIR flow cytometry. Which is more preferred? It's obviously FLAIR, right? FLAIR is also a flow cytometry method. You must have known about flow cytometry. Flow cytometry is a principle in which I attach many CD markers to say whether it's positive or negative. FLAIR is also a flow cytometry. FLAIR is actually a dye which is used in flow cytometer, right? So investigation of choice is undoubtedly flow cytometry only. FLAIR's flow cytometry or CD5559 flow cytometry, whichever it is, whichever is available can be used, right? FLAIR stands for it's fluorescent. I'll tell you, just give me a second, Swati. I'll just erase this. FLAIR is an expansion. It stands for your fluorescent aerolysin. Aerolysin is the component which is tagged with the fluorescent dye. This FLAIR actually binds to GPI. So when something binds to GPI, if the patient is having PNH, will it be positive in these patients or negative in these patients? FLAIR flow cytometry, will it be positive or negative in these patients? It has to be negative because my GPA anchor is absent, so it has to be negative in the patients with your PNH, right? CD5559 also is the same principle. It will be lost in case of a PNH, fine. I'm going to show you a flow cytometry image. You must have seen multiple flow cytometry images. Just look at this and tell me what's happening here. We can look any of this image. We'll look at this image first, right? Ignore that monocyte and your polymorphs. We'll look at the polymorphs alone, right? In this image, this part, when I have any data here, this is positive or negative. It's a FLAIR. You can see it's FLAIR flow cytometry. Here it is positive or negative. Undoubtedly this is positive, right? When I compare to this half, the lower half, this one is positive or negative? This one obviously is negative, right? So in this patient, I have PMNs are polymorphonuclear neutrophils. I have almost, like, let's assume 80% of the neutrophils which is having positive FLAIR, and let's say maybe 15-20% of the neutrophil is having negative FLAIR, right? So this patient, is this patient suffering from PNH or not? You guys know to interpret flow cytometry. Is this patient having PNH or not having PNH? Is it positive diagnosis of PNH or negative diagnosis of PNH? You know the principle, so tell me whether this patient is suffering from PNH or not. You know the disease, you know how flow cytometry works. You told positive or negative. I just want you to diagnose whether this patient has PNH or not having PNH. Okay, Ian has gone for biphasic, not having PNH. Okay, fine. So you already told me an information. You only gave me an information that PNH is an acquired disorder, not a congenital disorder, right? If it is an acquired disorder, can I say that only some of these stem cells will be affected or every stem cell will be affected in acquired disorder? You guys only said it's an acquired disorder, right? So answer this question. Will only few stem cells be affected or every stem cell will be affected in an acquired disorder? It will be only few stem cells, right? Because acquired, I cannot have all the hematopoietic stem cells have the same mutation, right? Perfect. So if only a few stem cells are affected by an acquired disorder, can I say the WBC or RBC or platelets which comes from those affected stem cell will have negativity, which is negative for your PNH, your CD55-9 or FLAIR, and the rest of the unaffected disorders, unaffected stem cells, will they be positive? Yes, because only few of them will have the mutations. Those will be negative, and the rest non-mutated will definitely be positive, right? So keeping in this in mind, now tell me whether can I say this patient is suffering from PNH or not? Undoubtedly the patient is suffering from PNH, right? So in PNH, be it 55-59 flow cytometry or flare flow cytometry, the only possibility is I will not have all of them being negative. So don't consider this patient as normal, right? Don't consider this patient as normal. This patient is suffering from PNH. Here also, it is said that even if 1% of the stem cells are negative for your flow cytometry, your flare or 55-59, my diagnosis of PNH can be made. It's not 100% always. Since in acquired disorder, I don't require 100%. Just 1% is more than enough, right? Okay. Swati, it is not X-linked. The gene is an X chromosome. It gets mutated, that's all. I'm not going to call it an X-linked disorder, fine? Okay. Lakshmi, flow cytometry is a very, very simple concept. Fine, I'll tell you the easiest way to interpret flow cytometry is a simple graph. When you have any cell here, which means it is positive for the x-axis and y-axis marker. Here in sense, it's positive for CD157 and flare. If it is here, it is negative for both x and y-axis marker. If it is here, it is positive for x-axis marker. If it is here, it is positive for y-axis marker, right? That's a simple way of interpreting flow cytometry. If you apply that here, this will be positive for both flare and 157. There are few tiny yellow dots here, which will be negative for flare as well as 157. Fine. Hope that's clear, Lakshmi. Fine. Okay. So keep in mind, it's not always everything should be positive in PNH. Even 1% stem cell having the mutation is definitely abnormal for me. With the help of history, Pancytopenia and your intravascular hemolysis, I can definitely call this patient as suffering from PNH. History is very, very important. Fine. Okay. PNH is a stem cell mutation. So can this patient, it's a stem cell mutation, can this patient develop leukemias? Is there a possibility that these patients will develop leukemias? Yes, these patients can develop leukemias, right? PNH can predispose to AML, acute myeloid leukemias, right? PNH also can dispose to aplastic anemia. These two came in your NEET exam, right? Both aplastic anemia as well as acute myeloid leukemia predominantly, but it can become any leukemia. Acute myeloid leukemia and aplastic anemia are long-term complications of PNH. We have to keep the patient on follow-up just to make sure we early detect these new things, and I'll definitely able to treat it better. Fine. Okay, great. So patient with PNH, what is the most common modality of death? I'm sure you know PNH patients, the commonest cause of death. That also is a PYQ. The commonest modality of death in a PNH patient. It's thrombosis, right? Generally, thrombosis is the commonest modality of death in a PNH patient, right? So you must have also read about a monoclonal antibody which is used in PNH. Can any of you tell the monoclonal antibody in PNH? The only purpose of the monoclonal antibody is to make sure there is almost nil thrombosis. It will reduce the incidence of thrombosis by 90%. Swati, the other one is aplastic anemia. What drug is that? You must have read it. It's a complement 5 inhibitor. It's eculizumab, right? It's eculizumab. Eculizumab reduces the risk of thrombosis a lot. Eculizumab doesn't prevent the complications of AML or aplastic anemia. That will definitely happen in this patient, right? Okay, fine. So can I say that treatment of PNH will be bone marrow transplantation? If I can give a bone marrow transplantation, remove all the defective stem cell and give a new stem cell, this can be taken care of. Fine. Okay. Just one more question. Am I right in saying that PNH patients will have pancytopenia? Pancytopenia is definitely one of the presentations of PNH, right? If a patient with the PNH has pancytopenia, how can you explain thrombosis? Shouldn't that be bleeding disorder? If there is platelet reduced, the patient should have bleeding manifestation, right? Not thrombotic manifestations. How can you explain thrombosis in case of a pancytopenia? Try to ask questions at any point of time whenever you read. Then only you're going to read more and you will definitely be improving every time you read. Okay. The reason for UPAR instance, I don't know what is UPAR. Let me know that. Perfect, right? Pratmesh is right. So the reason for your PNH is it's complement mediated lysis. The complement is one which is destroying my RBC, destroying my WBC, and destroying my platelets. That causes pancytopenia, right? So let's say I'm having an RBC here. When complement sits here, it can completely destroy it, like what we read in hemolytic anemias. It can completely destroy it, or it can partially destroy an RBC, which can result in a spherocyte, right? In an autoimmune hemolytic anemia, where complements are involved, this is the method of destruction. It can either completely destroy the RBC, causing intravascular lysis, or partially destroy, causing a spherocyte, which goes to the spleen and get destroyed. The same concept gets approved for a platelet. Again, a complement binding to a platelet can completely destroy, can completely destroy the platelet. At the same time, a partially destroyed platelet, what happens is it will get activated. Okay. I'll come to your thing here. It will get activated, right? See, urokinase plasminogen activator, that being low is not going to prevent thrombosis. It cannot initiate thrombosis. That's an anti-thrombotic person, right? So when that is low, the risk of thrombosis is more. But what causes the exact thrombosis is an activation of platelet. You must have read about something called as contact activation. Contact activation will happen. That will make sure the platelets are going to go and get stuck to my endothelium, which causes the activation and which causes thrombosis, right? Okay. And low plasminogen activator definitely not going to prevent this. Since it's there, it's not going to prevent it. So there's more risk of thrombosis as well, fine. Because PNH can cause thrombosis, there is one syndrome which is very, very common in PNH, and in many clinical scenarios, that will be the presenting symptom. What syndrome is that? It's related to liver. What syndrome is that? It's a case of a Budd-Chiari syndrome, right? So do remember that Budd-Chiari syndrome could be a presenting manifestation of PNH. It can also come in that way. Okay, one more question. I'll mute myself for next 30 seconds. Look at the question and comment on the answer. It's a simple one. Diagnosis. The history is more than enough for us to come to a diagnosis here. I thought it was an easy one. Okay, Ian has gone with B. It's an esophageal biopsy. Do you think measles and Whipple's disease is a possibility? It's not, right? A simple esophageal biopsy will easily help me to rule out Whipple's and measles disease. Measles should have been pneumonia and lung biopsy, and Whipple's disease predominantly intestinal lesions, right? So C and D options are very easily ruled out. So the only option left for me is these two. It's either herpes simplex virus or your cytomegalovirus. The simplest way of differentiating these two is both of them are viruses, both of them will cause inclusions, right? Cytomegalovirus, will it be basophilic inclusion or eosinophilic inclusion? Cytomegalovirus is going to be a basophilic inclusion. Perfect, right? So this will be a basophilic inclusion, and a herpes simplex virus will be an eosinophilic inclusion. Your Cowdery type A, type E bodies will be eosinophilic, pink in color, right? Perfect. So your outside of cytomegalovirus was basophilic inclusion, right? So the way of differentiating these two is based on the color. Now with this information, we'll go to the cell. Can I say that this is pink in color, right? Obviously it's eosinophilic. So since it's eosinophilic, the only possibility for me here is your herpes simplex virus, right? It cannot be anything else because eosinophilic inclusion, it has to be an herpes simplex virus here, right? So try to rule out options, and just based on a simple fact which you already know, you can easily come to an answer. Esophagus helped me to rule out C and D, and the color pink or blue helped me to come to a conclusion that is definitely B. The same history, same biopsy, I'm having basophilic inclusions, I'm going to go for your cytomegalovirus, right? So that's how you're going to solve this question. It's a very, very simple thing. Though the image looks a bit difficult, but you can definitely pick up the colors. If you can pick up the colors, you can definitely come to a conclusion, fine? Okay, I'll end it here today. If you're free at 10 p.m., we'll have an impromptu session on patient management. I'm just going to give you inputs from a pathology point of view. This might be useful for you when you become a postgraduate, because pathology is one of the important factors in arriving at diagnosis in most of the patients. I'm going to talk about what all you should keep in mind when you become a resident in order to arrive to a correct diagnosis, right? If you're free at 10 p.m., you're more than welcome to join the Unacademy app. It'll be just few cases which came in the lab. I'm going to use them to come to a conclusion. Let's see if you can come to a conclusion as well. Fine. Okay. Thank you for your time. If you have any doubts, you can let me know at any point of time. See you soon. Bye-bye.